Hello, students. Today, Liz Rayburn and myself, Sylvia Blancette, will be presenting on Alzheimer's disease and its possible link to anesthesia. The objectives we will cover today are listed here. We will explain the incidence and risk factors associated with Alzheimer's disease, associated pathophysiology, and describe the current state of evidence linking postoperative cognitive dysfunction to Alzheimer's disease. After reviewing the disease, we will discuss a case report and anesthetic considerations. Alzheimer's disease is a chronic, irreversible neurodegenerative disorder and is the most common form of dementia. The diagnosis of Alzheimer's disease is based on a positive history, neurological examination, and neuropsychological tests. According to the Diagnostic and Statistical Manual of Mental Disorders, a positive diagnosis requires the loss of at least two of the following: orientation, memory, judgment, language, or calculation. A definitive diagnosis of Alzheimer's disease, however, can only be made by autopsy of a patient's brain. Alzheimer's usually manifests as a subtle onset of memory loss, followed by slowly progressive dementia over the course of several years. The course of Alzheimer's disease is variable, and cognitive impairment, personality change, psychotic symptoms, incontinence, and gait or motor disturbances often occur. Memory impairment is progressive and destructive. The time from diagnosis to death varies, as little as 3 or 4 years if the person is older than 80 when diagnosed, to as long as 10 or more years if the person is younger. There is no cure. Here are some quick facts. Every 65 seconds, someone in the U.S. develops Alzheimer's disease. Alzheimer's is the sixth leading cause of death in the United States overall, listed as the fourth most common cause of disease-related death in patients greater than 65 years old. More than 5 million Americans suffer from Alzheimer's. It is notable that many more under the age of 65 also have the disease, but remain asymptomatic. Out of all of our seniors, 1 in 3 will die with Alzheimer's or another form of dementia, though Alzheimer's is the most common cause of dementia in this patient population. In 2012, 15.4 million caregivers provided over 17.5 billion hours of care. This equates to $216 billion in total. They project that by 2050, the cost of care for Alzheimer's patients will rise to $1.2 trillion. Furthermore, almost 2/3 of seniors with Alzheimer's are women. Of all people over the age of 71, 16% of women have Alzheimer's and 11% of men. The reason for the higher prevalence of Alzheimer's disease in women is not known, but is theorized to relate to differences in longevity, hormonal status, education, and other factors. Although the cause of Alzheimer's is theorized to be an interaction of genetics and environment, we know that the greatest risk factor is increasing age. However, those that develop early onset of the disease appear to have missense mutations in several genes. This follows an autosomal dominant transmission pattern and has a strong genetic predisposition. Overall, only a small proportion of Alzheimer's disease is due to genetic variants. The large majority of cases, over 99%, are late onset and sporadic in origin. The cause of sporadic Alzheimer's disease is likely to be multifactorial, with external factors interacting with biological or genetic susceptibility to accelerate the manifestation of the disease. Research shows that there are several known risk factors that contribute to the development of Alzheimer's. In this model, you'll notice that there are several protective factors listed on the top of the line. These include factors like education, physical activity, coffee intake, and mental activity. Beneath the line, you will note risk factors. Some examples include obesity, depression, smoking, unhealthy diet, and diabetes. Cognitive reserve, shown in this model, is depicted to signify the accumulation of positive protective factors influencing onset of disease. It likely accounts for the observation that a given level of neurodegenerative pathology may result in varying degrees of symptoms in different individuals. The concept of cognitive reserve is thought of as the ability of our brain to cope with damage by using compensation or different brain processes to retain the ability to function well, thus staving off the symptoms of degenerative brain changes associated with dementia or other brain disease. A greater reserve allows you to function longer if exposed to stressors like surgery. there is a large amount of evidence on epidemiological risk and protective factors for neurodegenerative diseases and dementia. Yet, the biological mechanisms that underpin the protective effects of certain lifestyle and physiological variables remain poorly understood, limiting the development of more effective preventative strategies. The two hallmarks of Alzheimer's disease are senile plaques composed of extracellular aggregates of the beta-amyloid peptide and intraneural neurofibrillary tangles, composed of abnormally hyperphosphorylated tau protein. Alzheimer's disease has a long preclinical phase in which amyloid and tau cerebral pathology accumulate without producing cognitive symptoms. It is unclear to what extent these degradations exist before symptomatic onset, and it is likely impacted by individual level of cognitive reserve. Another feature is the loss of connections between nerve cells in the brain. This leads to a decrease in acetylcholine, diminished CNS nicotinic receptor activity, and increased glutamate. This damage initially appears to take place in the hippocampus, the part of the brain essential in forming memories. As neurons die, additional parts of the brain are affected. By the final stage of Alzheimer's, damage is widespread and the brain tissue has shrunk significantly. It has been speculated that the use of anesthetic agents may be a risk factor for the development of Alzheimer's disease. Worldwide, 200 million patients undergo surgery under anesthesia each year. As overall life expectancy has increased, an increasing number of elderly patients are undergoing anesthesia. In addition, elderly surgical patients are more likely to have pre-existing Alzheimer's disease or be at risk for developing it. It is well known that post-operative cognitive dysfunction, or POCD, is a major problem for the elderly and patients with probable Alzheimer's disease. On the other hand, there are no clinical studies that clearly demonstrate that general anesthesia directly causes cognitive dysfunction in patients with probable Alzheimer's disease. POCD is a well-known perioperative syndrome as a result of anesthesia and surgery, but the exact cause remains unclear. In what way POCD and Alzheimer's disease may be linked remains in question. Research into this field is challenging due to the nature of experimenting on patients with the potential to actually inflict harm as a result of experimentation. Randomized controlled trials are often considered unethical and therefore retrospective. Observational studies are done instead. Also, studies utilizing animal models are used to determine the practical impact on anesthesia on biological life forms in terms of performing an intervention. We found two interesting studies relating inhalational anesthetics to Alzheimer's pathology. In a quantitative study conducted by Zhang et al., isoflurane was administered to aged rats divided into 6 groups, 1 control and 5 experimental. The same dose of isoflurane was administered to each group. After cognitive testing, each group was evaluated at different times over the course of several days. The hippocampus of each rat in each subgroup were examined. Protein analysis and quantitative real-time PCR analysis was done. Results found that isoflurane anesthesia ultimately resulted in formation of a beta plaques. In a different study, sevoflurane was administered to male rats under chronic intermittent hypoxic conditions. The findings suggested that chronic intermittent hypoxia induced cognitive impairments, elevated microglial activity, and pro-inflammatory cytokines in the hippocampus. These were further exacerbated by sevoflurane. This led to a downregulation of PPAR gamma expression. As a reminder, PPAR gamma plays an important role in anti-inflammatory circuits.
As we mentioned before in the incidence section, it has been found that there exists marked gender differences in the rate of cognitive decline in subjects at risk for Alzheimer's disease. Here's one study that we found that looks at just that. The study looked at data from the Alzheimer's Disease Neuroimaging Initiative to examine gender differences in longitudinal rates of change in cognition in 398 subjects with mild cognitive impairment, 141 of which were female and 257 male. The mean follow-up duration was 4.1 years, with some subjects followed over 7 years. The rate of decline in ADAS-Cog, which is the Alzheimer's Disease Assessment Scale Cognitive Subscale Test, in men versus women, found that women had 2.3 points per year versus 1.05 points per year in men. The effect of gender on the test scores basically shows that it was highly significant, and the variability of cognitive change was found to be much greater in women than that of men. So their conclusions: were that the analysis of longitudinal data over 4 years find that women at risk for Alzheimer's disease decline at twice the rate as men, and these findings suggest the need for further exploration of gender-related differences in Alzheimer's disease pathophysiology. The role of sex in postoperative cognitive and functional decline was also found in another study that explored whether exposure to general anesthesia would lead to a faster deterioration of cognition, function, and brain volumes in women versus that of men. So to study this question, the researchers reviewed 2 different research program databases that were examining cognitive aging, the Oregon Brain Aging Study and an Intelligent Systems for Aging Changes. Out of 527 total participants, 182 people underwent a total of 331 procedures under general anesthesia. The researchers found, as a result, that men exposed to general anesthesia during surgery declined in measures of cognition, functional status, and brain volume statistically significantly faster than men who did not have surgery. Women exposed to general anesthesia during surgery also declined on those measures and at a significantly faster rate than men. The difference was even more pronounced for women who underwent multiple surgeries with general anesthesia. As we mentioned earlier, there is no cure for Alzheimer's disease. Treatment instead focuses on control of symptoms. These medications for standard treatment cannot stop the already present neuronal damage, however, they may help lessen or stabilize symptoms for a limited time. The FDA has currently approved 2 types of medications specifically to treat cognitive symptoms. The first class are acetylcholinesterase inhibitors, such as Aricept and Exelon. These medications prevent the breakdown of acetylcholine, which supports communication amongst nerve cells by sustaining acetylcholine at higher levels. The second class of medication includes NMDA receptor antagonists like memantine or Namenda, and a combination of memantine and donepezil, also known as Namzaric. These are approved by the FDA for treatment of moderate to severe Alzheimer's. Memantine regulates the activity of glutamate specifically, as an overactivity of glutamate in the central nervous system is theorized to contribute to the symptoms of Alzheimer's disease. Additionally, caregiver education and family support are a part of a holistic approach to the disease. Current research is also exploring the potential neuromodulatory effects of cannabis, as cannabis has a known anti-inflammatory property. Animal studies have shown promise in proving that cannabidiol promotes a reduction of beta amyloid expression in cells, but no human studies have been done for confirmation. It would be premature to say that cannabis and related compounds have any effect on dementia symptoms or progression, but robust study designs with larger samples are needed to clarify the utility of cannabis in Alzheimer's disease. It is notable to realize that Alzheimer's is an approved diagnosis for medical cannabis use in some states. It's been found helpful to treat symptoms such as agitation and insomnia. Furthermore, herbal remedies are also often used, but their safety is questionable as none of them are FDA approved, nor are there testing standards in place to determine purity. Throughout our research, it proved difficult to find case studies with sufficient evidence to prove that general anesthesia in a high-risk patient later caused or hastened the onset of Alzheimer's disease. However, this case report highlights the potential for a woman who had a diagnosis of Alzheimer's prior to her surgery and shows how her medication regimen affected her outcome. A 74-year-old female with a history of type 2 diabetes and Alzheimer's disease presents for a right-modified radical mastectomy. She'd been taking donepezil 5 milligrams daily for 4 months. The patient was also prescribed metformin and glimepiride, but both of these medications, in addition to her donepezil, were held on the day of surgery. Preoperatively, the patient demonstrated slowed mentation, a fixed facial expression, and sluggish motor movements. Labs were within normal limits and routine monitors were placed. The patient was induced with 3 milligrams of morphine, propofol 100 milligrams, and rocuronium at 0.6 milligrams per kilogram for a total of 36 milligrams. The patient was mask ventilated for 3 minutes. Intubation was attempted but proved unsuccessful due to the onset of spontaneous respirations. Subsequently, the patient was administered 20 milligrams of additional propofol and 10 additional milligrams of rocuronium. Endotracheal intubation was then successfully achieved. The patient was placed on isoflurane, oxygen, and nitrous for maintenance of anesthesia. MAC levels were not mentioned in the study. At 15 minutes and 25 minutes, respectively, post-intubation, the patient began to spontaneously breathe again. Initially, rocuronium was administered at 15 minutes. The dosage was not reported. At 25 minutes, the patient began to breathe yet again, and vecuronium was utilized instead. Dosage again was not mentioned. The case took 2 hours and spontaneous respiration was achieved by the end of the case. Reversal agents were administered, neostigmine 60 mics per kg and glycopyrrolate 10 mics per kg. Afterwards, respirations remained inadequate. Case report does not mention exactly how they measured this, it just says inadequate. They didn't give respirations like rate or tidal volume. Subsequently, another dose of neostigmine at 10 mics per kg and glycopyrrolate, an additional 5 mics per kg, were administered, to which there was no improvement. The patient remained intubated. An increase in heart rate, blood pressure, and blood glucose was noted, and insulin refusion was initiated. Postoperatively, serial ABGs demonstrated an improving respiratory acidosis. Neuromuscular monitoring was not available at that time. The patient was awake, following commands and moving extremities purposefully. She was extubated and within 5 to 10 minutes showed signs of tachypnea and shallow breathing. She was placed on a venti mask at 50% and O2 sats fell to 85%. The patient was then reintubated and transferred to the ICU. The next morning she was conscious, well-oriented, with adequate spontaneous respirations and stable vital signs. The patient was extubated and observed and eventually moved out of the ICU and was discharged 1 week later. So the importance of this case report is to serve as a reminder that these patients who you take care of that are on acetylcholinesterase inhibitors such as donepezil may have inadequate muscle relaxation and also delayed postoperative neuromuscular recovery. A conservative anesthetic technique for the geriatric population with known cognitive dysfunction is indicated. It's important to consider that if muscle relaxants are used, that there might be prolonged effects associated with succinylcholine administration. These patients are often taking cholinesterase inhibitors like Aricept or Exelon, which prevent the breakdown of succinylcholine. Furthermore, Aricept also inhibits the action of non-depolarizing neuromuscular blockers by allowing for the mass action of acetylcholine at the motor end plate. This results in resistance to non-depolarizing neuromuscular relaxants, and therefore you will likely need more drug for the same effect. For reversal agents like neostigmine, these might not work as well, and you might have a failed reversal and weakness upon awakening. Often Alzheimer's medications will be continued up until the day before surgery, but they will still be at substantial serum levels the following day and able to interact with medications administered during surgery. For example, Aricept has an elimination half-life of approximately 70 hours. For those patients taking ginkgo biloba, the main concern is the risk of spontaneous bleeding associated with the inhibition of platelet aggregation. Similarly, concerns with cannabinoids include prolonged bleeding due to a decreased platelet count. For these reasons, it's important to perform a thorough pre-op assessment, which includes asking our patients not only about prescription medications, but also about holistic supplements and medical prescriptions for cannabis. So in summary, though the majority of people undergoing surgery have no lasting effects from the anesthesia, research has shown that older adults are at higher risk for long-term cognitive and functional problems following surgery with general anesthesia. For the geriatric patient population, special consideration should be made to limit anesthetic exposure and consider patient medication regimen when formulating an anesthetic plan. In closing, we have created a couple of knowledge check questions for you. So knowledge check number 1, what is the greatest risk factor for Alzheimer's disease? Is it A, gender, B, genetics, C, ethnicity, or D, increased age? The answer is D, increased age. Knowledge check number 2, if you are taking care of an elderly Alzheimer's patient who is currently on donepezil, what are the 2 possible effects of drugs like donepezil on neuromuscular relaxants? And this is a pick 2. So is it A, relative resistance to non-depolarizing muscle relaxants, B, a shortened duration of action of succinylcholine, C, an increased sensitivity to non-depolarizing muscle relaxants, or D, prolonged effects of succinylcholine? So the answer is A and D, a relative resistance to non-depolarizing muscle relaxants and a prolonged effect of succinylcholine. And in closing, for your reference, here are our references. And that concludes our presentation. Thank you so much for listening.